Hey, good afternoon, everybody, and welcome to the Board of Health meeting for Montezuma County. And with that, Bobby, I'm going to turn this over to you, and we can go from there.
Okay, good afternoon. Thank you all for coming. We'll just do a quick round of introductions. I'm Bobby Locke, the Director of Montezuma County Public Health.
Laurel Schaefer, Assistant Director.
Henry Leonard-Saunders, active here for the CIP discussion.
Amanda Mullen, County Medical Officer.
County Attorney.
Opening for Montezuma County Commissioner.
Jim Candelaria, County Commissioner.
Kent Lindsay, Montezuma County Commissioner.
Okay, did everyone have a chance to read the minutes from January, and is everyone good with them? Yes, okay, thank you. We'll move right along to our communicable disease update. I am going to basically work off of our public health nurse communicable disease, Julie Jacobson's notes off of this. She had a family emergency, and so she is not here today. So I'm going to share basic update. As far as COVID-19 goes, our contract with the state ends at the end of April. We had a COVID nurse, and her contract will end at the end of April. COVID is basically a communicable disease that we will be treating as such moving forward. So, and then we will continue to support like long-term care facilities, congregate shelters, jail facilities, any incident like that where they're seeing increase in cases. We will work with them and the state to help them navigate and make sure they have all their resources that they need. So as far as flu goes, flu vaccinations, back to COVID. Since we received our vaccine in September, we have only given 6 doses of COVID vaccine. Flu, we have, for this quarter, given 11 doses of flu vaccine. There have been a couple cases hospitalized. As far as RSV goes, since January, there were 16 cases, infant and child. 2 of those cases had already been vaccinated with the RSV vaccine. And other communicables, we have had a Hep A case, Giardia, 4 Giardia cases, 1 Salmonella case. None of those cases involved a child care worker or a food handler. And we have had, I have to look back on this, but we have had 20 animal bites this quarter. Yeah, it was 19, but we just had to add another one. Seems high. So, mostly dogs and cats. So, that I'd have to compare historically, but that seems high for a quarter. So,
Did they say what type, the circumstances around the bite?
we have that information most times in our database. Yeah. Some are.
People stopping and picking up animals, and I was wondering if that was contributing factor.
No, a lot of times they're pets. They seem to be pets. Most of them. I'm speaking very generic, but most of them seem to be the person's pet or another person's pet. They're not just strays. I think 1 or 2 have been strays. So, yeah, that number just seems high. I would have to look into that a little bit more. Narcan and fentanyl, we've given out 75 fentanyl tests and 32 Narcan kits. And we also provide those to community partners as well as the public. Measles, that's been in the news a lot lately. The measles itself has definitely been on the rise. On the CDC's site, as of March 28th, there have been 97 cases for 2024 in the country for measles. And it's been in 18 different jurisdictions, none in Colorado yet. Arizona is the closest state to us that has had a measles case. And in comparison, if we go back, like in 2021, there were 49 cases. 2022, there were 121 cases. In 2023, there were 58 cases. And now we're in 2024, 3 months in, and we have 97 cases. So that just gives you kind of a perspective on the numbers of measles cases. We do have MMR vaccine at the hospital. I know they have it at the hospital, and our health department, we give it. So the vaccine is available to those who want to get immunized and get their kids immunized. Obviously, people who are unvaccinated are at greatest risk for measles. Unvaccinated or under-vaccinated. And pipe up, Dr. Mullen, if you want to add to any of this. Just a little bit about it. Transmission is airborne, large droplets. They can remain in the air for up to 2 hours. The incubation period is anywhere from 8 to 14 days. And the infectious period is 4 days before the rash, 4 days after the rash. Humans are the only known host for measles, so it doesn't come from any other source. And so it's basically symptomatic treatment if you get measles. So is there anything you want to add to that?
One thing I would add is doctors practicing now, none of us were trained in an era where we saw a lot of measles, so it's not something we're used to seeing. So it's really important if you yourself or your loved one is under-vaccinated that they bring that up if they're having a rash. That, hey, I'm not vaccinated for measles. This is something you should be looking for. So I've personally never seen a measles rash. So, yeah.
I mean, online, you can go online and look at the pictures of it. There's a lot of information out there. Obviously, go to a reputable source to get your information, but they do. They have some very good pictures. So anyway, that's pretty much for my communicable.
I could probably got some pictures here stashed out somewhere.
My mom had measles and mumps as a kid, but doctors practicing now. We went through residency. If you're 30 years, 40 years or less into your career, we all went to residency within the timeline of when everyone was vaccinated for MMR. So, and that has eradicated those illnesses. So.
Okay, I'm going to move on to our department update, if that's good with everyone. Yeah, sure. That's a tough question for me to answer. I was actually surprised when I saw that we had 2 cases that had been prior vaccinated with RSV, but the RSV vaccine is kind of a rather new.
Brand new vaccine. Who we're giving it to is different this year, but it's a virus that we're vaccinating against that has multiple different types of viruses that you can get, multiple different kind of variations of that. So just like your flu shot, we're doing our best with it. So we're picking the most common strains of it, and it usually protects you and usually decreases severity, is my understanding.
The other factor too, I think, is, a kiddo could go, a parent could get RSV vaccine, and they could have already been starting to get sick, and they just don't know it. So, and people say that with the flu shot too. The flu shot is not a live virus vaccine, so it doesn't give you the flu. But if you were already starting to kind of get sick, and then you put something in your body, and then it just seems to kick in, and so those cases may have been something like that.
Inpatient pediatric side, it's been a rougher RSV year than the last 2 years for us here.
Vaccinated cattle and everything else for it. But as far as it stopping it, it don't seem like it does much in the animals. But it's mixed in with other IBR and BVD and different vaccines, and it doesn't, I don't know. I'm not sure that we do a whole lot with it. That's why I was wondering how efficient it was in people.
I mean, vaccines, I think, do work, especially like the proven vaccines that we have had for years, like the MMR. Okay, I mean, MMR truly does work. We almost obliterated it. Now it's coming back, and it's coming back for multiple reasons, but all those who are unvaccinated or under-vaccinated are clearly at risk. And it's very contagious. So, if you can prevent it, and it has years and years of proof that it works. So Anyway. Not that I'm aware of. Mm-mm, 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 mm-mm. We're working on getting a little more specific numbers, but one thing is definitely on an uptick across the entire state and including in this county is syphilis. It is, yeah. It's, yeah. It's becoming a huge problem. So, more to come on that. So.
We are updating protocols for testing too at the hospital, so we're trying to especially get our pregnant moms tested more often so that we can treat babies, and we're improving our protocol for that.
I should have brought those numbers, but I was on a call, an STI call with the state, and the amount of babies that are born with totally preventable genetic syphilis it's terrible. Like, there's no reason why a baby should be born and have syphilis. So it's because mom hasn't been treated. And so we really need to make treatment, we need to make detection, we need to make it way more available so that because there's been several babies born in Denver. Doesn't mean they were living in Denver, it meant they were delivered in Denver, who have been really sick. So, and it's preventable. So, okay. Our first really good news is our break room floor. I don't know if you need to come over and see our break room. We're so excited. We got flooring in our break room. Well, it wasn't done until yesterday. So it looks really nice, really nice. So Travis, are you listening to this? This is really cool. And Dustin and his crew did a great job. So thank you for that. Yeah. Everyone's excited. Okay, second thing on my list for department update is Melissa, our environmental health, OWTS. She requested for us to look at, us meaning us in the department, to look at our fee structure for OWTS. So it has not been increased in several years. So what we are going to do internally is compile the information. What does it cost to actually do a site inspection? And depending on what the need is on the OWTS, what's being done, are the fees appropriate for what we're doing, kind of thing. So we're going to be working on compiling that information and documentation, and we will bring it back to you all before the end of the year, probably more like the October meeting. And in hopes, if we're all in agreement and you approve it, then we will move forward for January of 2025 with new numbers. But we're going to do our research first. Okay. Any questions on that? I know we're one of the lowest in the state right now, but we need to do a comparison to see what it costs us to actually do it. So, okay. Let's see. The third thing I had, and this just came to me yesterday, and I'm basically asking you what you all think and what you would like me to do with this particular subject. I was asked by the policy committee, I think her name's Allie Morgan, with CalFO, there's a hearing next Tuesday at 2 p.m. in support of the Senate Bill 181. And it's a first hearing at the Senate Finance Committee. So she's asked a couple directors if we would be willing to speak for that simple 2-minute blurb. I would do it through Zoom if you would like me to do it. Are you familiar with Senate Bill 181? Well, what they want to do is, well, I don't know. Let me get to a different. Now, it's entitled Alcohol Impact and Recovery Enterprise. It's concern.
Maybe in addition to something like.
Maybe the enterprise piece is what they're adding to the bill, is what I'm wondering. I was under the impression it was a new bill, but maybe I'm wrong. But it's concerning the creation of the Colorado Alcohol Impact and Recovery Enterprise. The bill creates a bill summary. Here's the bill summary. The bill creates the Colorado Alcohol Impact Recovery Enterprise in the Department of Revenue. 2, and here's the purpose of it. Collect a fee from manufacturers and wholesalers that distribute alcohol within Colorado. 2, use the fee for alcohol and related substance use disorder prevention, early intervention, treatment, harm reduction, and recovery services and programs in communities throughout the state. And then it goes on to kind of talk a little bit about, how the enterprise board would have it would specify membership and the duties of the board. As of yesterday, they were still looking at making some changes in this proposal, but that's what it's about. And I was on a meeting with Dr. Bill Berman through CalFO, and he gave a really excellent presentation on alcohol and the impact of alcohol and the taxes that are currently charged for alcohol in the state of Colorado. And Colorado is probably one of the lowest states for taxing alcohol beverages in the country. And for Colorado, spirits are charged at $2.28. Beer is charged at 0.8 cents, and wine is charged at 0.28 cents. And then he had this other slide that showed comparison of tobacco and the comparison of marijuana and how they are taxed. And then alcohol was really, really tiny. So, and a lot of his work is about the impact that alcohol has on communities, the actual percentage of people who have drinking problems, and all of that. So that's what this is about. And I wanted to bring it to you all before I just was leaping on board to what I would be doing is talking about our community specifically, not the state of Colorado, just like our community and how alcohol impacts our community. So what are your thoughts on it? Would you like me to just lay low and let this pass, or would you like me to?
So the first question that I want you to ask him, then why in the legislature right now are we passing a bill which allows takeout alcohol, again, just like it was done in COVID? So we continue with this legislature to promote more alcohol, more alcohol, more alcohol, and then now we're trying to come on the backside of it. What are we doing is my question. Because as I'm reading this text here, and where is what do they plan? So it's got to go through a 5-year period of time before any money is then distributed. Am I reading that correct?
That I don't know.
And then who can get the money, and then is it going to just be for what?
So what is being discussed through the Public Health Institute at Denver Health is about how we could utilize tax dollars for education and prevention. That is how, and I'll just use this as an example. So for tobacco, okay, when they had the huge tobacco settlement, the tobacco settlement is what funds our Nurse Family Partnership Program. The tobacco settlement also funds tobacco prevention efforts. So it seems like oxymoron, I guess, but they actually take the dollars that they gain from lawsuits. The opioid settlement, that's how SWORD is working. So that's how they operate in order to turn it around to help with education and prevention. And I know that seems odd, but where else are you going to get the funds to educate and prevent further abuse? So, and this, what they're asking me to speak about is developing this, not the tax, but the actual enterprise.
Correct, and that's going to receive $100 million in the first 5 years, estimated. I mean, how is that then going to be distributed? Because it doesn't say that. Is that going to be through grants, through DOLA? How is that going to affect us? And how is it going to affect also with the 2 counties with the reservations on them? Because that is an impact which is even more significant, in my opinion, than anywhere else in the state of Colorado.
Well, and I think
So-
that's why they asked me to talk, because of the, where we are located, plus all the states that we border.
So as I read it, there's nothing for enforcement, there's nothing for,
No.
It's just creating
It's
an
an enterprise.
enterprise.
make it easier to get and we'll tax the crap out of it.
Well, it looks like the enterprise is going to then give out grants through the BHA or the BASOs. And then some of them would go to law enforcement, especially for like DUI enforcement, it looks like. And then treatment providers, public health, a variety of sources depending on if it's prevention, treatment, education. So I'm sure that there'll be a lot of back and forth about this at the legislature.
Right, and they may change, they may change even what they're presenting next week, what that actual,
I mean,
enterprise looks
obviously,
like.
listen
so.
in. I mean, that's my opinion. Listen in and see what, I mean, is it good or is it bad? I mean, I don't know. I can't tell you that, but
It's like they're going after a lot of
Our-
the manufacturers.
that's what they're going to do is the
Mm-hmm. Yeah, it's
manufacturers
not
of
the
it.
small,
How affected we are might be a good idea. So you.
So stay at the table. Stay at the table, I would think. I mean, I'm just one person here, but
Yeah, we've got to know what's going on.
well, the ask of me is to have a 2 minute elevator speech for our community in regards to that enterprise. And she did tell me that so far that bill is second on the list, and there's no exact time. Like, she was fourth on the list a couple weeks ago, and it took 4 hours for her to get to the point where she testified. I'm not going to waste 4 hours of my day. I can't do that. I mean, I can't do that in the course of what I have to do that day. So I am very much on the fence whether or not I should or want to do this, but I wasn't going to make that decision without asking my Board of Health if you even wanted me to.
well,
do
I
it.
can tell you that waiting in line could be 4 hours. The last time I testified, it was about that long. But I definitely think we should be at the table just to at least listen to the conversation, because then we don't have any clue of what's happening. But again, I don't, we promote this kind of stuff, and then we, on the backside, try to create enterprises to fix it, and it,
I think they're going to do it with or without us. But I guess one of my thoughts is why couldn't you say something along the lines that speaks to our community, but also put in that plug that when they create these enterprises and and this bucket of money, to make it accessible for those communities that need it the most, is of high importance also. Because that's my first thought when we were looking, and I was looking at this, and I'm thinking to myself, okay, well, that's if we get a grant. They asked us for a reason. But are we going to see that money to help our community? So maybe putting a plug in to say, make it accessible to the communities that need it most.
That would be my concern. I mean, we're going to raise taxes, and we know that when taxes get higher, that cost is just passed on to consumers. And then, what are we going to do? Create more bureaucratic positions in Denver that we're going to fund with that money? And another big bureaucratic fund that then can dole out and throw us some bones down here. I mean, that's how it seems to play out in real life.
This is a tax upon certain entities. Isn't this a ballot initiative question? Does this fly in the face of Amendment 1? I mean, it's getting close, if not.
Again, this is just to speak on behalf of our community in regards to the enterprise.
I mean, you would think that they could look at that and wonder.
I don't know. Maybe because we don't have enough information, I should not. But I don't know. That's why I brought it to you all to help me figure this out, what we should do.
Alcohol is still, last time I checked, our number one abused substance, and it kills a lot of people. maybe more so here than other places.
And just from me, I would say stay at the table and at least listen to the conversation. And I think I got a head nod from Kent and to see what's coming down. But I think really the question is, how do we promote just not alcohol? Because that's all we're doing in the state right now is promoting more and easier and easier, and people are not always responsible. Yeah.
With the legislature that's come down for tobacco taxing, I
Right.
have seen a way back off in smokers. I've seen people decrease at least how much they're smoking per day. And if this legislature would increase how much alcohol costs to the consumer, I think we would see a huge decrease in use.
And there's two sides to that. You can read things that say that increasing taxes does not affect people's consumption, and then there's the other side that it does. But neither here nor there, by increasing taxes, it does allow for education and prevention tools to be invested in. So, and there is a percentage, whether if you're addicted to tobacco or you're addicted to alcohol or whatever the addiction is, some folks are going to do it no matter what it costs. They'll do that rather than put food in the refrigerator. There's just a population that's going to do it that way. Then there's the other population who are like, wow, these cigarettes I'm paying $2 in taxes. I'm going to buy one less pack this week instead of, and so over time things shift. Addiction takes years to develop. It takes years to undo it. So.
I mean, I've seen a huge shift. I've had more people coming to me asking to quit
Yes.
than me hounding people to quit since the tax.
Yeah. Yeah.
One of the big kickers, I guess, for lack of a better term, is when they ban smoking inside public places, you have to go outside. We've seen a decrease in the restaurant, of course, they have to go outside, but not near as many people were smoking. But with alcohol, I don't think you're gonna ban that consumption.
No.
Yeah,
No.
it is.
Prevention up front. So the bad habits that are already out there are going to be tough to break, but prevent bad habits.
And maybe, I mean, I do think that alcohol is, probably a much bigger issue in our community than, I mean, I'll go out on a limb here. I think it's probably worse than anything,
I would agree.
including opioids, because,
Would agree.
probably if we sat here and polled how many of us drink once a day, how many of us do? I mean, it's very common, with the exception of Mr. Candelaria. But I mean, truly, it's much more accepted. You can do it socially. You can do, I mean, when you think about it, you go to breakfast in a ski town and they're offering you a Bloody Mary with your breakfast. You start your day with a Bloody Mary and you keep drinking the whole day long on the ski slopes. It's just, I'm using that as an example, but it's just accepted. It's an accepted practice. And what are we developing? What health habits are they? So, anyway, I'm.
We outlaw spring break.
Yeah. Yeah, make it really expensive.
They do that. I mean,
So maybe what I'm trying to summarize what I should do. So I don't think I will testify. I will listen as much as I can. And I think that we all know that alcohol is a significant issue for our community. Maybe for our next meeting, we bring some local alcohol stats to this discussion. And I mean, I don't know. I feel like there's a way that we can, and we're getting ready to do our community health survey, so we can incorporate that into our survey too, if people are honest and tell us what they're doing. I mean, I think it's something that we should look at, from a public health perspective. So.
Elevator spiel at hearing so that we are represented and at least they hear us. Like everyone's sitting at the table from the rest of Colorado and there's a big problem in Montezuma County. And then our name's out there.
I gave you mine, is why in another bill are we promoting alcohol, which is my biggest concern, and it's gonna pass, it's probably already passed. It's probably already went through. I don't get it. It's like, well, let's promote it, but then now, okay, let's tax it, and I'm not saying that that's a horrible idea, but why are we passing the bills previous to this one?
But we're not saying as a
Fair
county
question.
we're for or against this bill. I think what they're trying to
Right.
develop is what's going to happen with the money from this bill, whether it passes
I'm
or
saying,
not.
where's the money gonna
So-
go? How is it gonna affect us? Because we are impacted significantly
Yeah,
because of, we have a reservation,
yeah.
and I'm not
No, but that's a
I'm
realistic
not
thing.
targeting,
That's-
I'm just
No,
trying to be
that's-
realistic.
No, this is
of
something we struggle
have a
with.
significant issue and always have in Montezuma County. And again, I'm speaking for myself here. How is this money going to be spent? $100 million in a rural area is not going to go very far.
No, it's not.
It's not going to go very far.
But
You
could
know-
that be our elevator speech at this table?
That's-
Is that
yeah.
fair if we
For me,
are?
but I'm one of three.
And when, I mean, I always like to speak from a basis of knowledge. And without any more knowledge that we have of what they really intend with this bill, it's tough.
Well, my conversation with Ally yesterday, because I called her and I'm like, fill me in a little bit more on what this is, and she basically said that it's basically dealing with the enterprise. We are speaking to the alcohol issue in our community, and if the enterprise were to go through, you know, we're basically not speaking that we agree with the enterprise and what they're going to do, but that we have a problem in our county with alcohol, and these are the issues we see. That's really all that 2-minute speech is going to be. It's not about how you're going to handle tax dollars. It's not about, do we agree with Senate Bill 181? It's, our issue in our community is real. This is what, and I would obviously have some numbers, but she's like, come up with 3 really big bullet points you want to make with that, because they literally will cut you off in 2 minutes. So.
But testifying that we have a problem in this community is supporting this bill. I mean, let's not get it twisted. If we get up there and say that, we're supporting this bill. I mean, that's what it is.
Yeah, I am very much on the fence with it, because I see I mean, we definitely have an alcohol problem in this community, and I would say that for sure. But do you all want me saying that in a hearing? I don't know. You know, and that's why I didn't just decide this on my own yesterday that I wanted to do it. I came here to you all because I'm like, I don't know. I don't know if this is good, bad, indifferent. I think it's good, number one, that they asked us to do it, because there's only 2. Yeah. So, I mean, you can just look at the statistics and know where the problem is. So.
I don't think you admitting that we have that problem here is, what I don't like about this whole deal is we're just creating another damn state agency. That's what we're doing here. And are they really going to do anything?
Yeah, I can't answer that. I don't know.
Because I don't.
Yeah.
Show me very many of them that is done.
Well, I can only speak to the tobacco. Tobacco is huge. I mean, that has enabled for education prevention, and it has supported our NFP program, which is huge. So that settlement alone was worth that. And then, of course, the sword is in place because of the opioid settlement, you know. And, I mean, I wish we didn't have any of these chemicals to be a problem at all, but that's not reality, so.
Same thing for alcohol that they did with tobacco. It would be extremely helpful to our community.
Huge difference.
Because what they did with tobacco
It's
was
bigger
extremely
business.
helpful. All of us do. We all are biology. Like, there's not addictive personalities or not. There's biology, there's how your receptors respond to things compared to other people. Right? That's wild.
So I just had this little idea. I'm just going to put it out there, and I'm far enough away you can't kick me under the table. What if I wasn't the one, what if you, as our medical officer in Montezuma County, I don't know. I don't know.
So is it tomorrow?
No. It's next week. It's the 9th, and it's at 2 p.m. And right now, right. Well, she said they'll. Oh no. What I can do is I can reach out to Allie and say that you were interested in doing this. Can that work? And keep me posted on where on the conversation, because right now it sits at the second spot. So she said it won't be that far. And she said what's on the agenda so far is pretty simple stuff. So she doesn't think it's going to be the most, maybe 30 minutes that you're waiting to talk. That was her prediction. I don't know. I mean, thinking about the practice that you have and what you do, and you are a medical officer. And so it's a compromise. It shows us that we have representation there. And it's not a Montezuma County employee speaking. I don't know. I don't know. Ian, you're real silent. Okay, you're not a fan.
I don't think this is a legal issue.
Okay.
I think, it doesn't, politically, we can be on whatever side we want. But at the end of the day, the health department is trained to create prevention measures. And we're always looking for money. I know AA meetings that aren't funded that, some girls buying donuts for them. There's nothing for them. There's a lot. There's a lot we could do. If it's being funneled through the BHA, they're already standing and trying to get money out, but I don't know. At the end of the day, we're public health, and we're trying to create preventative measures, and there's really no money for alcohol. You don't see that.
I just think it's always problematic when small local government becomes dependent on big government and the funds it raises. And that's what I would say about it.
And CalFO in no way was twisting my arm saying you really should do this, but there's we would like to offer you the opportunity to speak on behalf of your community. And there was one other director that was asked to do it. So anyway, I'm fine if I don't do it. I think having Dr. Mullins speak would be a good replacement. And then it would remove county government from speaking. I think it's a compromise, but you all tell us what to do. You're the Board of Health.
I don't have any problem with you talking. It doesn't matter that. We got a problem. There's no doubt about that. We're not trying to hide it. The whole thing of it is, I just don't know that this doing it the way they're doing it, creating another state damn agency, is the answer, because it just sucks a bunch of the money out of it that they're collecting.
Yeah, and
It's
I
almost
don't
like they're
know.
creating their own
Yeah.
jobs up there.
Yeah.
That's my problem.
If
If they
it's
just
a
turn
valid
that money
concern.
over to the local communities and let them take care of it, that's one thing. But they're not going to do that. I guarantee you they're not going to do that.
Developed into block grants.
You get 80% of it, you're going to be doing good.
I think
Listen to the
you got a big
conversation.
problem That's going to generate probably very little money.
Okay. So I think as the public health director, I think I'm hearing what we should do is step aside on this opportunity. We're not going to speak. We will keep informed. And I would like to pursue something in regards to alcohol and the consumption of alcohol for this community. I absolutely think it's a big problem. I'm not saying a taxation thing, but something, whether it's an education or prevention funding that we can go after. I don't know what that looks like, but, yeah, but there may be after this comes to fruition. I don't know. And if Dr. Mullen would like to speak, she can do that as Dr. Mullen. And I can reach out to Ally and shoot her an email and see if that would be okay. Okay? Okay. Okay. Well, that took a lot longer than I thought. But thank you for the conversation. Okay. Our next department update, our CNC program, Colorado National Collaborative. I brought some samples of things here. We have been funded for providing bags for people experiencing homelessness, both male and female bags. And we are going to be tracking how many bags we give out to people. They can just come into our department and we will hand them bags, and I'll show you them in a second. And then these boxes here are bereavement boxes, and these boxes are for families who have experienced a loss by suicide. Someone in the family has committed suicide, and so we haven't finalized how we're tracking these. So we're not necessarily giving them out, and these hopefully won't go as fast out the door. But if you know someone who has had a suicide occur in the family, you just call us and we will be sure that they get a box. So I just want to take a second and show you some of the things in them, okay? So you know. So this is the bag. This has like some... Huh? Oh yeah, we got all kinds of goodies. So there's toothpaste, lotion, shampoo, chapstick, hand warmers in here. And then in the bag, we have wipes, we have a hat and gloves. This bag converts into a blanket. So, and then we are color coding them. This is a male one. I can't remember what the color is for the females. But, and then we will stick in like a bag of snacks as they go out the door. We'll stick in some snacks for folks. So, again, just something to help them. And yes, and we have a whole list here of resources so that they know where to get some additional they may have. Any questions about the bag? Okay. Then, our box, and these were both of these things were really put together with a lot of thought, trying to come up with things that are useful for folks. In here, if the family has children in the home, so we put a Lego kit. We have an Uno game. We have some tea and some mugs and a candle. There are seeds here. It says forever in our hearts. There is a card. Our coalition members all worked on doing handwritten cards for folks. There's colored pencils. There's a journal. There's some books in here. This one is called Learning to Breathe Again. A lot of thought and research went into putting these together for folks. And there is a really nice snuggly blanket in here too. So that's, and both of these are geared to suicide prevention and CPR approaches, basically, to whether you're here for this bag or you're here for that box, there's additional resources that help you. Have you all had QPR training? Put you all on the spot. No, obviously you haven't. You need to come to one of our QPR trainings. It's just something you can use every day.
Actually, didn't we do it in here? Didn't we do it during a meeting?
We did have.
I thought we did that about 2 years ago.
Arlena was here.
Pretty sure I did.
I feel like you did, but I'm not sure. Okay. Do you remember that?
We did it right here in a meeting.
Okay. Yeah, okay. Well, we do a lot of those we do a lot of those trainings. So if you're interested, you meet a lot of people out in the community, and so it would be really beneficial to have those just very commonplace language skills to know what to say and how to refer people when they're having ideas that they need some help. Okay. Okay. Well, we got some great trainers in-house now. So, you know, I think it's becoming more and more prevalent through the community, which is good. It's supposed to be a community mindset, so we can wrap our arms around everyone. So, okay.
Training too, wasn't it? It was like an hour?
Yeah,
45 minutes?
it's not very long. I will say though that when we did the training in the commission room, there was not, I don't recall anyway, breakouts or where we did actual, oh my gosh, yeah, where you role playing.
Yeah, no, we
Okay.
didn't do any of that. It
And
was
that
just the-
that's the kind of training that you want because you actually utilize it. So I think that the smaller training is not in a big setting like that. A smaller training is, I think, more beneficial. That's my personal opinion, but I think it is. You'll incorporate the information better in a smaller setting. So if you're interested, just reach out and we can hook you up with the training. And we can take the training places too. We've taken it to several businesses and such. Okay. Next on my list is WIC. We did hire our full-time WIC educator, which is great. We hired Katya Tutton, and so she is a quick learner, and she's doing really well with educating our clients. So Delilah's been working with her to get her up and running fully. In regards to the funding for WIC, so funding formula changes are definitely still in the works. They still haven't actually finalized what that dollar is going to look like because they've been having meetings on a weekly basis, and they're getting a lot of pushback from a lot of directors that the funding formula is not matching what the need is. But basically, we know that things are going to change. Their requirements, the thing that's specifically going to impact us is that their requirements aren't necessarily different, but they are enforcing the requirements now. And one role in particular is that director role. The director role is supposed to be an RN or a registered dietitian. And we have not had that for 13 years. So maybe in there we had once or twice we had a RN, but they just don't last. They move on to other jobs. So Delilah has rocked this, and she is the foundation. She knows WIC inside and out, backwards. She can do this program, and she's been doing the requirements because the state has allowed her to do it. Now, she is no longer grandfathered in, and every WIC program across the state has to follow these guidelines. So the guidelines are no different, they're just enforcing them now, whereas they didn't enforce them before. So we are going to be we have to make some shifts a little bit internally, but we are in the process of working through that. We met with our state contact today about that, and hopefully the options that we are thinking about are going to work. So, but the new thing is, that we've never had to do before, we have to apply for it. So we have to put in a request for application. So we will be bringing the grant form to you all before we submit that to ask to apply for the WIC program. And we have to have that submitted by June 16th. So somewhere between May and June 14th, May 1st and June 14th, we will be writing that process, so we'll need to come to you before that. So just giving you a heads up that that's what we have to do with the WIC program. Because we see 600 plus families in this community, and we want to keep it going. So, okay. All right, any questions on any of that? No? Okay. All right. CIP. That's next on my department, and then it's just going to blend into our CIP conversation. So just a little update fiscally. I'm just going to say CIP has been challenging. We still haven't received any payments on the program. And we've been doing it since when? October. So the system is ridiculous. I'm just going to say that. It's a federal grant. We have been paying our contracting workers. You know, Axis has been paid, the Cortez Fire's been paid, but we, the health department, have not been paid. So, yeah, it's very, very challenging. I'm going to let Laurel speak to some of the challenges that she's had, including all the information you had to put into the system.
Before you get started, I thought that CDS grant took care of all that for fiscal year 23 through 25, right? Was it 2-year?
So we are applying for that one this week. So when we ended, or when social services decided they didn't want to carry CIP anymore, we were not allowed to take over that grant. And they had already applied for it and written for it, and they would not reassign it, basically. And at that time is when Jim had gotten the Hickenlooper grant, and it's going to be easy, you're going to be fine. Well, it took Robert and I, like a few weeks just to write the thing. So it is a federally funded grant. I got a call from, I want to say it was Lauren Bobert's office who awarded it and congratulated me for it. And we wrote that it's a federally funded program. So we just let that year with social services go. And 2 weeks ago, that came back up for renewal for 24-25. And they are allowing us to apply for that. So we will apply for it. It'll kind of be the tail end of this federal grant. So right now we're in the federal grant. That was the one that has all the health department information on there that we wrote to, gathered everything from everyone. So a lot of things contribute to the difficulties in getting reimbursed. And thankfully we have Robert, so Robert Dobry's been helping me quite a bit. But long and short of it is we had to create an account, which we were doing, it was just fine. There's a SAMS account, there's a ClearGov account, and then there's a PMS account, which is a payment management system. So you have to have all these ducks in a row to get reimbursed. In the middle of all of that, they changed their system. So their system was changed, and it combined your social security number as a user, which I'm a user. Travis is on there as well. Long and short of it, the system combination was not smooth. I basically had to upload my driver's license probably 15 times, do some facial recognition, upload my social security number, and try to separate it from my daughter's student loans that were under my husband's social security number. Ridiculous. Long and short is we're in. We're good. I got it figured out. Took me like 3 months to work through this. So we're good. Right now we're just waiting, and I know Ellen Black called me yesterday because they need to verify our banking information, which I did get an email that said there was a big backlog on that. So there are a lot of reasons why we haven't been reimbursed, but hopefully we're on the other side of that mountain. And so when you look at the reimbursement, it's almost it's about $120,000. October, November, December, January, February. And I'm working on March right now, so I haven't gathered March together, so yes.
And I sent you all this sheet to give you a snippet of what the cost entailed just a month ago.
And this funding will carry us through the end of September of '24. And then the funding that we're getting from CDS will be October, November, and December. And after that, we'll have to, we still haven't looked for additional funding, but that's about what we've got so far. CIP is funded until December of 2024 right now. Not including the other funding that is being held by admin. that some entities put into, so we might have a month or two in there.
And that money's there, but that money, at least in my mind, should not be utilized to keep the program going. Like, that's for if, the van has some major catastrophe and we need to do something with it. We could pull from that. But we should be able to sustain this program without falling into that, I'll call it reserve. So yes, we either today or tomorrow, we are submitting the expansion of behavioral health grant, the safety net grant is what they call it. But it's only for $100,000. So it costs about $30,000 a month to do this. So that's 3 months. So that's where we are financially. We had a great conversation the other day with Haley in regards to, I'll just pick up where we left off with the Board of Health meeting last time. We were asking, what are the long-term impacts of this program? How can we get that information so that we get all the stats that we get for our monthly report, which I gave you all a copy of that. Travis can pull it up on the screen if you want to look at it again. That shows you how many clients they've seen, how many individual clients, how many calls, and if you want, Haley's a far better descriptor of what the important numbers are on these graphs, if you will, because then it gives you a picture, a snapshot, which is all really good information, but it answers the immediate of what they're doing, but it doesn't answer what happens down the road with these individuals. What changes are occurring, Access can provide some of those numbers as far as who had appointments and who didn't, kind of thing, but Access can only provide Access numbers. So we still don't have a big lens of what is this program actually making long-term changes in people's lives. Obviously not every person's in ready to change, right? But if they have, I'll just use the term case management, on an ongoing basis, develop rapports, and people keep checking in. And CIP does an excellent job with the clients that they see, but they have a limited amount of time to do that. They're not going to be able to just keep seeing them once a week and, checking in, why didn't you go to here, why didn't you go to there, that kind of thing. How can we help you with these things? That's what a case manager does. And in my mind, as public health, I feel like that piece is missing for this program. So for us, in public health, we're about education and prevention. With that lens, that's the work we do. So if we're going to look for funding, I'm not used to writing law enforcement grants. That's not what I do. So, if we want to have a public health lens and look at long term, then I feel like the funding that we need to seek is more of a case management. But we need to keep CIP going too. So this is all part of the conversation that we want to talk about today and what you all think about the cost of running the program, the numbers seen, kind of how you feel. Do you want Haley to highlight each one of these that's significant? Remember how you were telling us the 80 versus the 110?
Yeah, if you could quickly go over that, Haley, then we can. Yeah, I can't read. Actually, I think that big screen back there is the easiest one to read. I can't see those. And then when I print it out, it's too tiny. What'd you say, Travis? It is. You have to blow it up on the screen, but when you print it out, it doesn't do any good. It's too tiny, even with my readers. So, which screen do you want to start on, Haley? Is this the right one? CIP dashboard? Okay. Yeah, that's got the 110.
So at the time this report was, this is the February, so let me just do an overview of the quarter, because that's just 1 month in time. So what you're looking at is the total number of calls, the number of patients served, number of initial calls, so whether they're dispatched by 911 or a referral placed by law enforcement or EMS. So year to date, they've done 324 total calls, and that is for 100 individuals. So there are people that have utilized the team multiple times. So dispatched by 911, they're doing a lot of follow-up. They're doing a lot of follow-up, and we're able to see what types of calls they're doing, whether that's welfare checks, suicidal ideation, intoxicated subjects, helping assess. They've even had, runaways. They do a lot of agency assists, citizen assists, all of things what they do, like rapport building, general support, connecting to resources, which could be healthcare, food, a lot of family conflict they're still seeing. And then they're also working on large-scale solutions, which require the hospital and law enforcement and EMS, to put solutions in place for people with really complex needs. So they're kind of running the gamut of, checking in on people. Hi, how are you? Trying to build a relationship so that person has trust in them. So maybe at some point they do want to make a change or they're interested in getting additional help to, getting somebody placed in inpatient care, which is a huge achievement. The program has had 4 inpatient placements since it started, which is, that's a big deal. We only had 37 placements in substance use treatment in the Southwest region last year. So 4 of those came just from this program. It takes a lot of work and collaboration and documentation and all of these things, and getting the person to go. These were all voluntary admissions. They're doing, I think a big piece of the program is the individuals that they're contacting get to make choices about how they engage with the team. So, for the most part, since January 1, 53% of people have agreed to follow up. The rest said no. So not everybody is ready to accept help that they're given. Not interested in making a change at this time, has other things that they're more focused on. But it doesn't mean the team stops. They'll continue to outreach and try to connect with somebody as much as they can, anytime that person comes through the system. And they'll do follow-up until the person says, don't follow up with me anymore. So they're making a lot of impact. The majority of the calls, we've seen a shift over time. The data is showing me that law enforcement, dispatch, EMS are all really developing skills in identifying what they're looking at because the types of calls have changed over time. And so we're seeing more mental health, like specifically mental health, specifically substance use. Whereas the calls came in all over the place, kind of different reasons, identified in different ways. And I think everybody's doing a really great job of, like, this is exactly what we're seeing, this is what you're walking into, and setting the team up for a successful interaction with the individual. So that's been really cool to see, taking what they've learned and applying it to how they're sending people out and the information that they're sharing with the team. Is there anything else that stood out to you guys that you wanted me to talk about?
So how about remember when we were doing the calculations of what it costs per visit? Do you recall
It was from anywhere from like around, depending depending on the month. It's kind of hard because only 3 of the months have been two teams. It averages between probably $250 a call to $270 a call. And that's 2 professionals, the van, the gas, everything. So it's not terrible. You know, like if I were to go meet with somebody, I think it would cost me about $150 for an hour's worth of support. No. No, that's
calculation is only what we have control,
what it's costing.
what it costs the grant.
I'm not sure. I think they are in one of the grants, but I think we do have some, but it's not, we haven't paid them yet.
$5 for each call unless the call is associated with a initial call. So if the initial call is associated with it, are we getting charged ×2 or? What's the question?
No.
It's a really good question that I don't think that we have not heard from dispatch. We haven't received an invoice from dispatch.
Yeah.
And I don't believe in this grant we're just getting ready to submit, we
Yeah.
did not put a dispatch line item in that.
They were in the very first grant and then not in subsequent grants because they weren't getting billed and I hadn't heard anything else. I think Jim was kind of the conduit for program to dispatch, so I'm not sure. I will say,
Per call, I think we're paying 75, almost $76 a call, right? Roughly per call. So that number at 275, 75 is, and I'm not sure how you slice $100 for each person. It seems a little bit low to me, but if those fees are not in there.
one thing that really stands out is the arrest rate, because law enforcement is on scene. They should be on scene at least to clear the scene for the majority of these calls, with the exception of the follow-ups, for things that they know what they're walking into. We have 1 arrest since January of 2024, and the arrests are generally because there's no other option. They have to bring someone in, depending on the warrant. So kind of it really is kind of a good follow-up to yesterday's conversation about, bringing people into the jail and looking at that list that Vicki was working from. The types of calls that that the team is responding to are really diverting people from formal actions, whereas they might have ended up in the jail prior to the team existing. So that's kind of interesting to see how that trends. One thing I did not look at yesterday when I saw Vicki's data was the time stamp on the arrest. So it'd be interesting just to see, are all of these arrests happening at a time where the team is off duty? It could be an interesting analysis to see if the impact is as significant as it looks based on the data. So,
Because the team is operating 7 days a week now.
yeah.
So, I'm pretty sure it was December that they got 2 teams established. So, but the hours are what?
11 and a half hours.
Okay.
I think they went from 8 till 10 or something.
I don't think
Yeah,
it was-
and then they never want to go home. They always want to help. They have to tell them to go off duty. So they cover 11 and a half plus, I would say that. Usually, I think it's like 8 to 10-ish.
Do we have any data on ER visits too? Because those people that are getting arrested too are going to end up sitting in the ER for an ER clearance and $270 or whatever. It's $500. That's way cheaper than an ER visit.
Yeah, so we have, since January, of the contacts that they were involved in, 38 needed a medical transport to the hospital. And then 9 of those CIP actually transported to the hospital. So that's likely if they were doing follow-up, and I'm aware of some of the cases that they were involved in. And so it has to be, of course, medically necessary for that to happen. But anecdotally, I mean, Kelsey Jarman has said that a lot of the friendly faces that they've seen, she's the ER director, a lot of the friendly faces that they see, they're not seeing as much. And we're working on getting some data from Southwest, because at one point someone indicated that some of the stats regarding behavioral health related admissions to the ER they saw a significant decrease when they were doing an analysis for another project. So I'm working on following up to see exactly what those are and what areas they're seeing decreases. You know, the hospital's been really incredible in collaboration, especially with some of those friendly faces, like putting a plan in place and notifying staff, if you see this person, this is what we're going to do, this is the plan that we have, you know, and really wrapping around some of the individuals who need a higher level of care, because the team couldn't do any of this. They can do a lot by themselves, but there is a whole network, you know, behind them of community agencies, hospital, law enforcement, really coming together to provide the services.
Okay. So just one other thing, and Haley, this was that additional email you sent to me with like kind of the breakdown of what you've been able to capture from your internal systems.
Yeah.
And so you're okay if I just spew out these numbers so people can hear that, right? So there were 23 detox days, 3 ATU placements, 170 crisis contacts, 4 inpatient placements, which Haley already spoke about, 72 psychiatric diagnoses, 42 behavioral health screenings for admission to treatment, 103 outpatient behavioral health services, 653 primary care visits. Now that snippet is an Axis snippet. We don't know, there's likely more that happened, but we don't have that. So again, that just speaks to my case manager cheerleading. So I guess number one for me concern is funding, because without funding there is not a program. So there's a big problem, and we also don't have both contracts in place right now still.
So we're just waiting on the one contract because Axis signed the contract. So we're
Axis's
done.
contract is done and ready to be signed.
So CFPD is what we're working.
The Cortez Fire
Cortez Fire.
Protection District's contract is not done, and
So why is theirs not done? Number one, and number two, then can we go to a different EMT? Can we advertise and go somewhere else? I mean,
well,
I'm just asking
yeah,
a
so
question.
I mean, I think that that's a reasonable question to ask. We did receive, we sent their contract to them. We received a contract back from their attorney that was marked up significantly, and changes need to be made to it to make it palatable for the grant and for the county. And the CFPD attorney has not responded. And Bobby, I think you dealt with the fire chief, you know, so it's.
Conversation with the fire chief on other topics, but he handed it, Rick Spencer's the one who I was dealing with, and he was dealing with the chief, and the chief sent it after the board meeting to the attorney. And that was, I don't know, 2 months ago?
So if they're not responding at all, they're not interested in it. So do we, because I know originally when we put this together, we asked every fire department to give us a cost and or the hospital, right? So why don't we just send it back out? If we don't have a contract and it's been 3 months. Why are we waiting on that? Let's just send it back out.
Well, I can certainly email the chief or pick up the phone and call the chief and say, are you interested in this still? And if so, we need it like tomorrow. And if they're not, then we're gonna go a different direction. I mean, I have no problem doing that, because it's been, I mean, we've been wanting to get this off our plate for a couple months now, because technically there's not a sign there, and we haven't done the Axis one because we want to do both of them at the same time, because they're in unison, they're a team,
And
so.
It's a Denver,
Yes.
it's a Denver attorney.
So,
And so,
yeah,
I mean,
just,
it's really appropriate for me to talk to the attorney, and I reached out to the attorney, and so that's where we're at.
I just think just for, I'll just call it courtesy to let the chief know that we still haven't gotten that back from his attorney. And, you know, we're up against the wall now, so we need it. And, because he may have just, because he handed it off to the attorney, he might have just like forgotten about it. I don't know. But I, you know, because when I got the one back from his attorney and I saw the markups, I immediately contacted Ian, and Ian's not had luck with communicating.
so
with
then
anyone.
are we good with, as a courtesy, reaching out to the fire chief? And if they're interested, fine, then let's get it signed. And if not, then we'll,
Do something else.
yeah, we'll go down the road and do something else, because we don't have a contract at all. But they're
We
still
can-
providing the services.
Oh, yeah, every day. So, uh-huh.
So,
As of
yeah,
January.
as a courtesy, I would think, reach out and
Okay.
find out what the holdup is, and if,
I don't know, but I'd be willing to bet that the chief doesn't even realize that it's still sitting at the attorney. And we're at this stall, and Ian has tried to communicate, but there's no, it's like radio silence. So,
I think the contract's with us, but their attorney needs to get in touch with us, so, yeah. I mean, the marked up contract is with us, but obviously there's a lot of changes that have to be made to that.
to say that the contract, all it needs right now is signatures. No, there's back and forth that needs to happen.
Not even
that the-
close.
I
Right.
think that the back and forth did happen in the inception, and if they've changed their attorneys, we don't
I
have to
believe they have.
negotiate this
I-
contract. So,
This is a different attorney and
Yeah.
a different take on that contract, and the
So-
contract as it was sent is
Right.
substantially
in my
different.
opinion, if they don't want the contract and they've sent back a marked up copy, they're not interested, let's just move forward. Because
Well,
we're not, are we really interested in negotiating that contract? Because we had it written for us,
We had to do back and forth with Access too.
but it was relatively
But
simple.
it wasn't
This
near
is-
as complicated.
It was fairly, it was
Yes.
different.
It was,
I
it
mean,
wasn't.
We were talking
yeah.
about pretty,
Yeah.
pretty small
Yeah.
markups versus some pretty substantial
Yeah, these are some big ones.
changes. It's a big difference in the markup between what we
And
received.
everybody saw this contract in the inception. Every fire department, the hospital, everybody saw it and everybody was okay with it. So now that they've changed attorneys, the game has changed.
Well,
I'm
and
not
I will
sure-
say that I think, you know, the battalion chief now is different from last year.
Mm-hmm.
So his procedures may be different, you know, and so maybe they have a different attorney than they used to have before. So the whole process is a little more convoluted than it was before. But we started this months ago.
But for their attorney to not be getting back to us, that's the issue. So yeah, reach out as a courtesy.
Well, that takes care of the contract conversation.
About funding,
Yeah.
aren't we?
Yeah, I mean, we're good through December, but I also don't. I'm not quite sure what funding we should look for either, because I keep saying the case management piece, but I really think that if public health is housing this program, then public health needs to use a public health lens to some of the work, which means case management. And Access does case management for what they can do. But that CIP van can't be out once a week at each of these people's homes and checking on, I mean, that's not even feasible. That's not even what the crisis unit is supposed to be for. So, we in public health are willing to bring in a case manager and house them in our department and make that happen. We have to seek funding for it, obviously, but do we have that be part of the overall arching funding that we're looking for, or I don't know where we want to go with it. If CIP is going to stay the way it currently exists with 2 contracting agencies, I don't know.
Well, I think that's a bigger question than a decision today. I mean, there's a lot to think about with this. Obviously, the funding for the program itself, we have to take care of if we want the program to proceed, because I know that originally, and Commissioner Copenaper, you weren't here, but we put that $300,000 in the beginning to get the program off its feet, and we were assured by everybody that they would be able to fund this through grants. So I'm a little concerned that, I mean, if the funding isn't there, it's going to fail. It's going to fall apart. Is that what you're saying?
Just clarification, we weren't part of that
I understand that.
conversation, okay?
You were
So,
not.
no. But the program is a good program. We see the work it does. There's no question about that. What are the long-term impacts? We can't answer that. We need to figure out a way to answer that in order to justify sustainability and in order to find funding for sustainability. Those are the major, upfront issues, I think. And then the secondary ones is it working? Having contracted folks doing this, I think they're doing a good job out in the field. It's just that we can't get the answers that we kind of want to know how about the sustainability piece. So, anyway. So I don't know how all you want us to move forward. Do you want us to, well, first of all, do you like the case management idea? Of having someone who is tracking, we can get the information.
So all the data would come from internally for us. For anything that we need to see and have, we would have it all.
If it's our employee doing the case management, yes. And we would be able to say they were followed up at Access, they were followed up at Recovery Center, they were followed up in Durango, wherever it was. Excuse me. We would have more information on that, and it wouldn't be, we wouldn't be sharing people's private information, but we would have those intricate details of what were the barriers, because that's another piece that I feel like we can hear really good success stories and we see good numbers and stuff, but there's barriers. People are hitting barriers out there in this community with the CIP program. I mean, it's reality, right? Nothing's perfect. So what are those barriers? How can we improve them? And I don't know what they are. So these are just, to me, it's part of the whole picture, the whole package, and to make this grow and make a shift in our community.
So how do we run a cost-benefit analysis? I mean, we're seeing 100 people, right? Is what you said out of the 326 calls last year, 100 of those basically are the people that we're seeing. So those people have used the system a couple times each. So 100 is the cost that, I'm not saying this is not a good program, and obviously we voted to put the program in play, but the cost-benefit analysis, if we're only affecting 100 people out of 26.5, I mean, are we?
And the question is, are these 100 individuals, or was there repetitive calls in these 100?
They are repetitive. There's
So
3.
we don't know the real effective rate.
So that right there
Is the
is where a
piece for
case
the
manager.
manager.
Yes, exactly.
How come
So,
CIP is not generating this number?
well, they do follow up on people.
Yeah.
But that doesn't count as a new encounter. That's the same person that they're now checking in with, which a case manager could be doing
So I guess
instead
what
of
you-
having CIP.
What you're telling me, because we're not far enough into this, if we have a case manager and we could get another year's worth of data, we could actually see then, is it really the cost versus the benefit? And again, because at some point in time, it sounds like the grant funding is going to dry up. Kind of
I
what I'm
mean,
hearing.
I
Yes or
hope
no?
not.
can write for more,
Yeah,
Yeah.
and
but we
And-
have to have data to write for more.
And
And-
in the 2 years it's been up and running, they've served 446 individuals, and that's 1,700, over 1,700 calls. They'll have their second anniversary next month. So that 100 people is 100 people in just since January 1.
Correct.
Yeah. So 446 since they started, over 1,700 calls. I think part of it is not being able to see the whole picture, right, because of different systems. So understanding the impact on the ED, because those costs do impact all of us for a rural community hospital. Uncompensated care is a problem. No one wants to be in a position where the hospital is ever at risk again. And so keeping people out of the ED so they can focus on their skill sets is really
Well,
important.
Out of the ED also, and then our jail also.
Out of
I
the
mean,
ED.
There's two different things there that
Yep.
I think that we had all had that conversation when we started this, because that's a huge cost to us equally. Not the emergency department, but the jail is a huge cost to us too. So I think that was one of the factors that really pushed us towards this program.
absolutely, absolutely.
Yes.
This
Which is a
initially was,
long-term impact is to keep those people out of jail and or
Right.
the ED.
and initially, when we think back when we first started talking about this program, it was about decreasing the impact on law enforcement.
Yep.
And I think from what I'm hearing and what has bin said, it absolutely has had a decrease on law enforcement, even though a lot of times they're called to the scene, but then they can disperse. So in that respect, I think it's done its job. But even in the beginning, the thought was in my head, and I think I had shared that, but it wasn't under us, was the long term. Because you
So
can
then
help
it-
people in crisis, but then what?
So then it sounds like really to look for the funding to create or to have this case management is kind of what the recommendation is what I'm hearing. Because we are good for funding for the program itself till the end of this year. And then we have to look at additional funding.
Well, we have to look at it long before the end of the year.
Well, no, I understand that, but-
But yes,
We have to
we
get
have
going
the
now.
funding to get through.
My concern, and I know that Commissioner Lindsay and I had talked about this when this started, was the impact, one, to our law enforcement. Yeah, they are called to it, and hopefully they're there for 10 or 15 minutes, and then they can go do what they need to do.
Right.
But then just, bigger for us is keeping them out of the jail, and the emergency department also.
Yeah.
That's a huge cost that then become potentially non-paying.
Yeah.
Well, and then taking it further from a public health lens, it's making change in their lifestyle, potentially, so that they don't have recidivism. They don't keep going in this circle and circling again.
So
And
what do you
so-
guys think?
I think
Shoot for the funding for the case manager, and then,
Yeah, you should look. Because we can't fund it.
that was, we had said that up front. We would do the initial cost to start it, and then it was gonna be up to the partnership of everybody to to work collectively to get this thing done. So I think if that's what the recommendation is, what I'm hearing is that we look for the funding right now for a case management and then to see where we're at. And then hopefully you then can apply for more of the CDS.
Is there any potential to add it to the public safety sales tax, or is that a done deal? 'Cause-
No.
No? 'Cause-
Make it simple, no.
okay. That's just what most communities are looking at for
Yeah.
ongoing sustainable funding. So it becomes, a taxpayer burden and not a agency burden.
And I would just add, when talking with Robert and just looking for funding, looking statistically, there are a lot of people in the older age bracket that are being, that are calling or being visited. So, we could go look at AAA funding. Maybe there's something we could do. If there's some sort of it's taking the burden off of law enforcement. We are all assuming that. We don't have the hard data, but everyone says that, and we do need that data. Then we could look at some of that funding. We can look at public health funding and maybe mesh everything together and be able to do it. But it will take work. And I do know a couple of our cities and towns are very interested in funding it as well. They're committed. So, but it's just a couple thoughts.
So moving, oh, God, it's 3 o'clock. So at this point, we will start searching for funding to fund a case manager. And then we will start seeking funds, hopefully not federal funds, for CIP. Because that's, it's completely inappropriate for anyone to have to put their personal information into a grant that is for employment. Completely inappropriate. So I wouldn't do it. So poor Laurel had to do it. I know, but I just didn't want to, I just think that's overstepping boundaries that should never have to happen. So I'm not interested in seeking that funding again. So, and it was a nice chunk of change, so it was great, but I'm not willing to do that.
It was not as easy as it was portrayed.
No, it was not. So,
The grant, the funding, reimbursement.
yeah, which we haven't had yet. So, anyway,
But hopefully it's on track, is what she said.
Yeah,
that's what they say.
So that the last 2 quarters we can get reimbursed for.
There was a boat that was on course too.
Straight to an iceberg.
I won't throw out the anchor, I'm just gonna keep going.
And I don't know if I'm the captain that's going to stay with the sinking ship. I don't know. Oh my gosh. Oh dear. All right. Okay, so we have a sort of a game plan for CIP, and I will reach out to the chief this afternoon, fire chief. Okay. So I will let you all know what he says. Okay. Okay. All right. Well, I think we've covered it all, unless somebody had something else, but we're over time. Okay. All right. Sounds good. Thank you. July, what's the date of my next meeting? 2nd. Does that work? Okay. All right. Thank you.